Hello, everyone. Thank you for attending our Gynecologic Oncology Annual Symposium. For those of you who don't know me, my name is Jocelyn Chapman, and I'm part of the Gynecologic Oncology faculty here at UCSF. In my time with you here today, I wanted to highlight the topic of immunotherapy. Many of you might have questions about the role of immunotherapy in your cancer treatments or in your family members' cancer treatments. And you might also be curious to have a better understanding of how and why the immune system interacts with cancer. So we'll go over some of those concepts today. Robert Weinberg and Douglas Hanahan were two scientists who wrote a landmark paper in Cell back in 2000, which highlighted 6 hallmarks of cancer. These were 6 capabilities they proposed a cancer cell must acquire in order to become a cancer. And this framework has been updated to the 14 hallmarks that you see illustrated here in 2011. Avoiding immune destruction was added in 2011 as the research in the intervening years had identified the importance of the immune system for surveillance and destruction of cancer cells in our everyday lives. It is estimated that about 7 times per day, a cell with malignant potential is identified by our immune cells and destroyed before these wayward cells have the opportunity to grow, divide, and become a clinically relevant cancer. There are many ways a cancer cell might hide from the immune system, and we certainly do not know all of them. But one example of how some cancer cells hide is illustrated here. These are T cells on the left, the little blue cells, and these are immune cells which can help in the surveillance of our bodies. They run around in our circulation and stop off in our tissues to attack and kill any cells that don't have the correct set of proteins on their surface. So T cells ignore cells that belong, and they destroy cells that don't belong. Many cancer cells display a protein called PD-L1 on their surface, and this tricks the T cell into thinking that it's a healthy cell. When PD-L1 is expressed on a cancer cell, the T cell passes it by, thinking that it's a cell that belongs. But immunotherapy drugs have been developed that hide this PD-L1 receptor from the T cell. It allows it to unmask the tumor cell to the T cell so that it can recognize the cancer cell for what it is. The T cell will then be able to destroy the cancer cell. In a landmark trial of recurrent, heavily treated cancers, we were able to demonstrate that blocking PD-L1 on the tumor cells should result in significant cancer cell death. This graphic shows colorectal, uterine, pancreas, thyroid, and many different cancer cell types. But what these cancer cell types all had in common was a defect in a DNA repair mechanism called mismatch repair. Of all the cancer types, 17% of endometrial and 4% of cervical cancers have this special type of DNA defect. Cells with mismatch repair defects cannot repair their DNA errors well. And what we have come to understand, one of the consequences of this DNA defect is that the tumor cell makes a lot of very abnormal proteins. These abnormal proteins are then displayed on the cell surface, and they are very stimulating to the immune T cells. So cancer cells that are stimulating to the immune system will attract these T cells, and the T cells could presumably kill the cancer cell, assuming that the PD-L1 signal on the tumor cell is blocked. Unfortunately, ovarian cancers only uncommonly have this type of DNA defect. Which brings us to a question, which is an area of ongoing scientific discovery, which is why do some cancers not respond to immunotherapy? We certainly don't have time to dig into this topic, and I wouldn't be any kind of expert on it, except to say that the concept of cold and hot tumors, I think, is helpful. Cold tumors, like most ovarian cancers, do not respond to immunotherapy. Hot tumors, like mismatch repair deficient cervical or uterine cancers, respond very nicely to immunotherapy. I've used the PD-L1 and T cell illustration to help us understand immunotherapy, but this is an extremely simplified picture of what is going on biologically. There are actually many, many different types of T cells and other immune cells that have many, many different functions. In cold tumors, there appear to be increased populations of immunosuppressive cells that provide an extra layer of protection for the tumor, allowing it to evade currently available immunotherapy treatments. At UCSF, we screen all uterine cancers for mismatch repair deficiencies, and we also get this information for any cancer that undergoes molecular testing with the UCSF 500 test. Any advanced or recurrent gynecologic cancer is sent for testing with UCSF 500 so we understand the DNA defects in the cancer and hopefully identify a way to be able to target that particular cancer. But in cancers who have, in patients whose tumors have a mismatch repair deficiency that recurs after chemotherapy, immunotherapy is usually an excellent choice and can provide patients with prolonged and sustained remissions. In uterine cancers without a mismatch repair deficiency, a drug called lenvatinib, when added to the immunotherapy drug pembrolizumab, appears to sensitize some of these tumors that were otherwise immune cold to the immunotherapy drug. At the bottom part of the screen here, I'm showing the overall survival curve for a trial that was published in February of this year, 2022, that demonstrated that pembrolizumab, when combined with this other medication, lenvatinib, that the combination was better than other second-line chemotherapies for mismatch repair proficient uterine cancers. Immunotherapy in cervical cancer has also been used with remarkable benefits. On this trial, patients with recurrent and metastatic cervical cancer were randomized to receive the standard of care chemotherapy or to receive the standard of care chemotherapy in combination with immunotherapy. These survival curves show that patients who received chemotherapy with the placebo had a worse survival compared with patients who received immunotherapy combined with chemotherapy. This was published in November 2021, and we have been incorporating this medication into our practice. In ovarian cancer, the focus has been on what can be added to immunotherapy to turn these immune suppressing tumors into immune stimulating tumors. I expect there to be some big breakthroughs in the coming years as we better understand the interactions between the immune system and ovarian cancer. While everyone is probably at least somewhat aware of chemotherapy side effects, immunotherapy often has a reputation for being the easier cancer treatment with fewer side effects. That's warranted in some ways. It is important to know for sure that these drugs are often very well tolerated with minimal or no daily side effects, which is very different than chemotherapy, which causes daily side effects. However, not infrequently, these medications can damage our healthy organs and can cause a severe inflammation in any organ in the body. Another active area of research is to better understand these reactions so we can prevent them and provide effective cancer treatments that pose as little threat to healthy organ function as possible. Well, this concludes my comments for today, and I generally put up a slide at the end with a quote from one of my favorite authors, Atul Gawande, who encourages me as I think about our efforts to treat cancer. Diligence and a willingness to try are all that is required to make things better. I also would like to point out that this is a photo of Dr. Chen and I from a while ago when I was her resident. You can see Dr. Chen there in the foreground. On behalf of all the gynecologic oncology faculty at UCSF, I want to thank you, patients, and their families who partner with us as we seek to continually do better and improve our care of gynecologic cancer.